Good morning, everyone. We're going to go ahead and get started. Thank you for listening today to our webinar entitled Coping with Challenging Behaviors After Brain Injury. My name is Annie Randolph, and I am a Neuro Resource Facilitator with the Brain Injury Alliance of Iowa, and we are very excited to share this webinar with you today. We will be recording this webinar, and we'll have it archived on our YouTube page in the coming days, so look out for that. And then also, we will save time at the end of the session for any questions you have, so please feel free to type in your questions into the chat box as you think of them, and then we will respond to them in the order they appeared at the end of the session. No CEUs will be provided for the webinar. However, we will provide a certificate of attendance through your email after the session. So now I would like to introduce our guest speaker today. Our very own Courtney Sand is a neuro resource facilitator with us here at the Brain Injury Alliance of Iowa, and also a licensed and board certified behavior analyst. She has 17 years plus of experience in California and Iowa in the field of applied behavior analysis and mental health, including various autism programs, school districts, and an outpatient mental health clinic. Most recently, Courtney worked for an in-state community-based neurobehavioral rehabilitation service site as their behavior analyst. Courtney attended California State University, Stanislaus, where she received her master's degree in psychology with a concentration in applied behavior analysis. Courtney is passionate about playing a part in the process of behavior change and celebrating progress towards seemingly small but very significant goals. Thank you all for participating today, and I will go ahead and unmute Courtney and let her get started.
Can you hear me?
Yep.
Perfect. Good morning, everybody. Thank you for taking the time to come and learn a little bit about brain injury and how to cope with challenging behavior. As Annie said, I currently work for the Brain Injury Alliance of Iowa as a neuro resource facilitator, and I'm also a behavior analyst. As Annie mentioned, prior to working for the Brain Injury Alliance of Iowa, I worked for another provider in the field of brain injury with extremely challenging behavior. If you can think of it, I've probably attempted to manage it from verbal aggression, property destruction, physical aggression, elopement, self-injurious behavior, substance abuse, mental health issues, sexually inappropriate behavior. So a pretty large gamut of challenging behavior. I love what I do. I love being part of the behavior change process and helping people work towards their goals. It's very challenging work, but at the same time, it's very rewarding. So my presentation is kind of in two parts. The first, I'll talk about just the impact that brain injury has on a survivor and the people that love them. And then the second half will be impact-based strategies, hopefully tools that you can take and use with you in your work. I like to start out a lot of my presentations with this slide. I am both professionally and personally inspired by my Grandma Dee and my late Grandpa Jake. As you can see, that's me and my daughter and my grandpa. He passed away in December from the second of two brain injuries. He had a massive stroke and complications from ALS. So I saw and experienced what it's like firsthand to support and to be a caregiver of someone with a brain injury. For the 4 years prior to that, I was on the other side of the door, so to speak, as a professional. So it really showed me what it was like to sort of walk that journey with my grandma as his primary caregiver and walking through their grief, both individually and as a couple. And it taught me the importance of being fully present with another person and what a gift that is to give. So I'm going to start off talking a little bit about why brain injury is considered to be the silent epidemic. I saw a couple quotes online that I liked that I felt like kind of captured this. It felt as though they expected me to walk on a broken leg with no crutches, and no one signs a cast for brain injury. On the outside, someone can look seemingly fine, and you oftentimes don't see a lot of the issues underneath, especially if a survivor doesn't have an obvious head wound, physical issues with walking, communication deficits. So they can look quote unquote normal on the outside, but there's a lot going on underneath. I had about a year ago, I had a wrist fusion, And after I had surgery, I had a big, bright pink cast halfway up my arm, and I had lots of empathy and people asking, "How's your wrist feeling? Hey, let me get the door for you. How's recovery going for you?" Versus oftentimes the experience of somebody with a brain injury or mental health issues, they're much less likely to be asked, "Hey, how's your brain injury rehab or recovery going? How's your depression? How can I help you manage your symptoms? What can I do to help?" So it's often a very different journey for somebody with a brain injury. I like this slide, especially this quote: "Not all wounds are visible, so walk gently in the lives of others." I've always thought that the world would be such a different place, truly, if we saw everyone as having a story full of joy and of pain, rather than taking difficult behaviors at face value. Because we all know that challenging behaviors can be they can be irritating, frustrating, offensive, exhausting, but there's always a story there underneath that I think it's important to hear. Silent epidemic. So brain injury is often referred to as the silent epidemic because symptoms are not always immediately evident. Like I said, you can't always see it on the outside. And the public has limited knowledge about what a brain injury is and what it means, including survivors. Talked to a number of people just since working for the Brain Injury Alliance that didn't even realize that they themselves had a brain injury. Concussion is often thought of as separate from brain injury, but it is in fact considered a mild brain injury. My grandfather had had 2 strokes and didn't identify himself as a brain injury survivor. So even among survivors, there's some misunderstanding out there. Having a brain injury can cause an increased susceptibility to mental health diagnoses such as anxiety, depression, schizophrenia, and substance abuse. There's a 34 to 49% prevalence rate of mental illness with individuals that have had a brain injury compared to 18% in the general population. I talked to a survivor last week at a support group who thought her brain injury was less than because she can still walk and talk. So I have had a lot of conversations with survivors that feel like they're often not seen as, quote, disabled enough. And then as a result, they receive decreased empathy and support. Behaviorist communication. I believe that as a behavior analyst, that it's purposeful. In most cases, there's always a reason for its occurrence. Behavior represents an individual's best efforts to get their needs met, whether it's socially accessible or safe. It's their best effort to get what they're looking for. And when we only look at behavior, we stop seeing the person underneath. When we look beneath behavior, though, we see a struggling human that's usually in a great deal of emotional or physical pain. And they need help getting their needs met in a different way. And that's where we step in as professionals, is to help teach alternate, more appropriate methods of doing that. And then just seeking first to understand the why behind behavior. Behavior management is hard. And I think if you take time to sort of see the why behind someone's behavior, it really does help to soften your response and approach. Storytelling. So this is an opportunity for connection. So everyone has a story, and I know you guys know that, and it's unique and worth hearing. Be intentional about carving out undivided quality time to hear someone's story. Ask the survivor to share their story. I've often worked with a lot of staff who were kind of hesitant to do that. They felt like they couldn't ask. Um, Ask who somebody was pre-injury, as well as who they are now, their new identity. If they don't want to talk about it, they won't. But I've found that many survivors appreciate just being asked, just that you have an interest in hearing it. And it really is a beautiful way of establishing rapport and developing a relationship, which will then help as you move through teaching them and redirecting behaviors, things like that. Um, it helps to be able to fall back on their story and how difficult their journey has been and continues to be. Preference assessments. I always think this is a really important part of the process. So I recently heard in a presentation the quote, "Nothing about me without me." And I love that. It's just a very person-centered way of thinking. Preference assessments can be a very informal process. It looks like a structured conversation, really, and getting to know someone. And the goal is to help identify somebody's wants and needs, their goals, their interests, their preferences, what they like, what they don't. And then doing this kind of at the onset of meeting somebody can help identify and build on hobbies and leisure activities that you're going to maintain or teach, um, which can be difficult for a survivor due to change in their cognitive and physical abilities. In working in a group home setting with survivors, I often found that many of them um, no longer had hobbies. They may not have had many before, but they weren't able to do them now. So a lot of times it would be just kind of going between, um, drinking coffee or smoking a cigarette or sitting outside. So we had to, with many, teach them new interests. So doing a preference assessment can help with that. Most importantly, this process gives an individual a voice and it makes them an active part of the process. And and then taking those details and incorporating it into their life, however that looks, whether that's um, in creating a daily schedule for them, the therapies that they would be interested in participating in, um, cognitive rehab. So if you in a behavior support plan, so if you align what you know about a person and their voice into the creation of those things, the process will be that much more successful. Again, behaviorist communication. So getting into the habit of looking for reasons for behavior can reduce the tendency to blame people for the things that they do and making assumptions that there's no way to change behavior. It can often feel that way. I have felt that way sometimes too, even as a behavior analyst. But the reason I love this field is because um, it's optimistic. I feel like there's always a way to make a difference. Um, and then also just looking for reasons for behavior can make the individual feel heard. And it takes a lot of practice to do this um, because our initial reaction to behavior can be um, behavior that's scary or disruptive or confusing or offensive. Behavior management is a process. So making the individual feel heard is huge. I'm not going to spend too much time on this, but in behavior analysis, we believe that people engage in behavior for a reason. And it's kind of broken down into these 5 categories. So there are 5 basic functions of behavior. The first is to access or obtain something. There's something that they want. The second is attention, whether that's positive attention or attention given because they're doing something that they shouldn't be. Someone's trying to avoid something, someone's trying to escape something, or automatic reinforcement, which is sensory based. I'll talk a little bit about this. So the goal is to look under the surface of behaviors to understand what the individual is trying to gain by engaging in them. So are they seeking attention or help? A lot of times I've seen this manifested in somebody engages in, and these are going to be pretty extreme examples, but engaging in property destruction because staff will then call 911, which is reinforcing. That sort of show of force and the police and the law enforcement showing up can be very reinforcing. Making sexually inappropriate comments because in response, a person might be shocked or disgusted, nervous laughter, that can be very reinforcing. Somebody who is working on cognitive rehab activity and they swipe it off the table. Um, at face value, somebody might perceive that as they're just pissed or they're not motivated, they don't care. But in reality, it could just be they need and want assistance, but they're too embarrassed or frustrated to ask, or they don't know how to ask for help. Trying to obtain something, this can be a thing. It can be, oftentimes I've seen it be just somebody wants a can of pop, so they elope to try to get down to the gas station. A cigarette, it could be anything, an iPad. It could be a particular staff person. It could be law enforcement. They want to get somewhere specific or engage in a specific activity. And then the last one is sensory stimulation. And there's numerous, just endless ways that I've seen this manifested where it could be head banging, nail biting, hair pulling, breaking glass, mouthing objects, swallowing objects, picking at skin, rocking back and forth, because even if it sounds painful or not pleasurable to you or I, for that person, they're getting some sort of reinforcing sensory input. So those are kind of the 5 functions of behavior in behavior analysis. A functional behavior assessment is something that a behavior analyst will usually facilitate. And I like this quote. I just saw it the other day. So because you cannot reduce a behavior until you stop feeding it, and you can't stop feeding it until you find out what it eats. So the point is, we're always looking for that reason. Why does somebody do what they do? The process of doing a functional assessment It identifies the factors that influence behaviors of interest. It provides a basis for interventions that are designed to change that behavior. As a behavior analyst, we're not ever trying to fix a person. Instead, we really do try to work to modify the environment and the way we approach a person so that they're more successful. I'll talk a little bit about this, the kind of the ABCs of behavior, kind of break them down a bit, and then we'll talk about the impact of brain injury and then those strategies. So the ABCs of behavior. Oftentimes we take something that's called ABC data or antecedent behavior consequence data, and basically it considers what happens right before and right after a behavior's occurrence. It helps determine the function or the why behind behavior, and that's so critical because it then drives the interventions that should be implemented to manage it. It really does make your interventions more effective, and it takes out a lot of the guesswork where you might feel like you're throwing a bunch of different strategies and nothing's working. Kind of the everything but the kitchen sink approach. It gives you a much more structured, function-based way of looking at behavior. And so I'm not trying to teach anybody how to be a behavior analyst. Rather, just encouraging people to look more deeply at the why behind behavior. Why do people do what they do? So antecedent is the A in that ABC that we were talking about. And that is just a fancy word for triggers. So it's an event that sets the occasion for behavior. So in other words, it occurs right before behavior does. So it asks the question, what happened right before the behavior occurred? It can be either external or internal. External factors in an individual's environment, like it's too loud, it's too crowded, it's not warm enough, it's too bright. Oftentimes, a trigger could be peers engaging in challenging behavior, and that's a trigger. And a lot of times it can be something like the staff that are currently on shift could be a trigger. Internal states are things like they have a headache, they're hungry, they need to use the restroom, they're tired, they're in pain, or they're experiencing hallucinations or delusions. So there could be a lot going on internally that we're not seeing. Kind of going back to hearing someone's story is ask somebody what their triggers are if you have the opportunity to do so. It's almost always appreciated. Be curious, not judgmental. This is a very helpful thing, is just to ask somebody what is it that triggers you to be when you get upset? What is it that does that? There's a lot of insight to be gained in that process. Antecedent. So again, looking for patterns. It's all in the detail. So asking questions like, where does the behavior occur? Is it at home, during medical appointments, at work, during PT, or running errands? With whom does the behavior occur? Peers, staff, community members, family. Oftentimes, you'll see patterns emerge like males versus females, young versus old. A lot of times I've seen some persons served challenging new staff versus veteran staff to see if they will consistently implement a behavior plan. And then sometimes management versus non-management staff are treated differently. When does the behavior occur? Certain times of day, shifts, days of the week. After a home visit, coming back from a home visit is often a really difficult time for somebody living in a residential setting. They've been around people that love them and who they love, and coming back and transitioning is hard. Before medical appointments, that's another one that I've seen. A lot of anxiety there. What activity is the behavior occurring during? Non-preferred versus preferred activities, structured versus non-structured activities, a new routine versus just kind of the same old routine, an individual versus group activity, shift changes. That's often a difficult time of day for somebody in a residential setting. There's a lot of things happening. Attention is less available. The quality of the attention is less available. Meal preparation, times where attention is diverted to something else, can be really difficult. And then what are others doing when the behavior occurs? Is there being a task being presented? Are staff assisting someone else? Are they providing attention to someone else? Just lots of different ways to gather information. It's also valuable to take into account distant antecedents, often called setting events. And these occur not necessarily right before the behavior, but they help sort of set the occasion for it happening. Things like medication changes, taking those sort of things into account, including refusals, somebody refusing to take meds, the amount and quality of sleep the person had the night before, current health conditions, They're in pain, they're sick, they're thirsty because they're on a fluid restriction. A lot of times, very commonly, um, I would see the frequency and intensity of behaviors skyrocket if somebody had a UTI, the big one. If somebody is constipated, that's another huge one. And then, or somebody recently had a seizure. All of these things can sort of set the occasion for the likelihood of challenging behavior. Upcoming holidays or anniversaries can be really tough. And then again, coming back from a home visit. So consequences. These are things that immediately follow as a result of the behavior. It asks the question, how did the people around the behavior respond? Did they ignore the behavior? Did they process that person's feelings with them? Did they give them something? Did they take something away? Did they give an emotional reaction? Did they put the person in a physical hold because they were being unsafe to themselves or others? Did they call 911? So lots, again, endless ways somebody that can attempt to manage a behavior, but it asks, how did the people respond? And then through that data collection, you can find out kind of what maintains or feeds that behavior. Consequences can increase, decrease, or have no effect on the occurrence of a behavior in the future. So just wanted to give you a little bit of information on kind of how a behavior analyst, and I mean, not even a behavior analyst, how we look at behavior and that antecedent behavior consequence um, pattern. And then this here will kind of transition into the next section of the presentation where I'm going to talk a little bit about the impact, and then we'll get into those strategies that you can use. So physical impact. And there's a lot more than I have here. I just wanted to hit some of the common ones that I've seen and worked with. So obviously motor and physical skills, impaired mobility, one-sided neglect, after a stroke, contractures where they can't maybe open up their hands fully, difficulty with balance, range of motion, strength, coordination. Oftentimes, post-injury, brain injury, that individual is in pain. Often they have persistent headaches or migraines. They have pain with movement, which a lot of times means you might see behaviors before like a physical therapy session because it hurts. It physically hurts. It emotionally hurts. So that can play a part. Communication impacts, difficulty speaking, understanding, reading, writing. Hearing issues are common where their hearing is now sensitive or poor. They have a constant ringing in their ear, which I can't imagine. Vision can be impacted, where it's sensitive or poor. They have blurred vision, double vision, a visual field cut, where they can only see up to a certain point, and then there's nothing. I talked to a gentleman the other day who is um, blind in one eye and has tunnel vision in the other, and I can't imagine. So vision can be impacted, and then just overall fatigue and the ability to maintain stamina. You or I kind of, and I think of it like a phone. At the end of the day, you charge your phone, you wake up, it's 100%. Some of the brain injury, they don't ever wake up fully charged to start their day. Their battery doesn't get there, so they have less to give as far as their ability to maintain stamina. In the area of communication, what you can do, and this will kind of start jumping into some strategies of, and a lot of these might seem common sense, but they're very powerful. So honor and validate communication attempts. Um, ensure that that individual has a voice. So just a way to communicate with the world around them, whether that's a call light in their room, um, verbal communication, gesture, sign language, a low-tech communication book, a tablet, an eye gaze software. There's all sorts of communication systems out there. Use the individual's name first to get their attention, make sure they're attending to you, and then ask or tell them something. You might have to take breaks. Communication can be really hard for somebody who is living with a brain injury. So you might have to take breaks and then come back to it. Shelf the topic and come back to it at a later time. And then just be patient and allowing for that extra processing time. Avoid saying, and I've caught myself doing this, but just being aware of it. So avoid saying things like, use your words or I don't understand, and then giving up on the interaction. Because it can be frustrating for the survivor as well as the person they're talking to. Instead, a very sort of powerful thing that I found is saying something like, hey, I'm sorry, I'm not understanding what you're trying to say, but I appreciate how hard you're working to tell me. And I can tell that this is something important to you. You have something important to ask or say. Let's work together to figure this out. Can you tell me in a different way? And that might be when you get a piece of paper, maybe they can write, or you look for a visual or something like that. One speaker at a time. More than that can be auditorily overwhelming, can be confusing, hard to focus. Avoid open-ended questions. Instead, ask yes or no questions. So instead of asking somebody, what do you want for breakfast? And it's hard for them to come up even with the options um, on top of actually saying something like, hey, we've got a couple options for breakfast. Would you like eggs and sausage? Yes or no. Would you like cereal? So providing those options and giving them an easier way to answer them. Avoid double barreling questions and directives. So instead, break those down into individual steps that are much more easy to manage. They're much less overwhelming. And then accompanying your verbals with gestures, facial expressions, signs, whatever you can to aid in understanding as you get to know what that person needs. In the area of cognitive and executive functioning, what this sort of looks like in somebody with a brain injury is the need for more processing time to make sense of information. That's where that patience and extra time comes in. Problems with planning and organizing, difficulty with starting tasks and or finishing them, kind of seeing them through, maintaining concentration or getting easily distracted. Perseveration or getting stuck, kind of brain lock on a topic. I see this a lot, kind of the rigid thinking. Poor memory, confusion and disorientation, difficulty with judgment and problem solving, impulsiveness, so acting before thinking through the consequences, and then disinhibition, so that social filter. As far as poor memory, something that I've learned just in my 5+ months at the Brain Injury Alliance is something called confabulation. And so this is where a survivor might give false or unrelated information because unconsciously their injured brain is attempting to fill in memory gaps. And they can be genuinely unaware that the information they are giving is wrong, and they're not intentionally or maliciously lying. So I thought that was interesting and worth mentioning. As far as what you can do as somebody who's supporting someone with a brain injury is, again, some of these are going to seem simple, but they're powerful. So introducing yourself at the onset of every exchange. Don't assume that I know myself, I'm horrible with names. Don't assume that somebody is going to remember your name or who you are, and they might likely be too embarrassed to ask or say, hey, I've forgotten, what's your name again? So just introducing yourself at the onset. Posting and regularly reviewing orientation visuals. I worked with a gentleman who his brain injury was very, very new, probably a month and a half, and he was in a group home setting, and it was heartbreaking because he would forget his name, he would forget where he was, why he was there, so he was terrified a lot of the time. Very confusing, scary place to be, not knowing why he was there. So we made visuals to put in his room, kind of anchors in his environment. Very simple, just Microsoft Word, type these out, laminated them and post them. Things like my name is, or I live here because I have a brain injury from, I am married to, my children's names are. So those can be very, very helpful anchors to sort of bring somebody back to the present. Label and color coding themed, functionally related items. So, kitchen cabinets and drawers, keeping, bathroom, paperwork, things organized in a way that makes sense. Keep them clustered together. Designating a home base for frequently used items that may get lost a lot, like a phone, a wallet, keys, or a med planner. Utilizing compensation tools. I couldn't live without the ones that I use. So things like a planner, to-do list, checklist, notebooks, call logs can be important for individuals that I've worked with who make calls almost to an obsessive level to one person over the course of the day, and then the next day and the next day, to the point where staff have received calls saying, hey, this is bordering on harassment, simply because the person forgot that they had called, or what was the message that I left. I can't remember the last time that I called my lawyer. What did he say? So keeping track of some of those details can help. And then considering assistive devices. My grandpa, after his stroke, we had a very neat phone that I hadn't seen before, and it was an old rotary phone. So a non-cell phone that we're used to with a cord. And then the buttons were pre-programmed, so he didn't have to remember phone numbers because the faces of the people that loved him were on the phone. All he had to do was push the person's face and it would ring them. So we were able to control who he could reach out and contact, and made it easy for him to do that. Um, and then there's really fancy things out there like med planners with different alarms, personalized alarm clocks, lots of really neat things. As far as processing time, so being patient, again, allowing for that extra processing time, and then frequently check for understanding as you're talking to someone with a brain injury, making sure that they're following, they're understanding. Hey, do you have any questions? Does what I said just make sense? Inviting them to let you know if something doesn't. Frequently checking in to see how they're doing as far as needing help if you're in the middle of an activity, rather than letting them reach the point where they're overly fatigued or embarrassed or frustrated or wanting to quit, checking in to see that they're doing all right. And then teaching how to self-monitor and request help, however this looks. I just put one example on there where I think the individual was working on like a cognitive activity, and there was just like 3 note cards out in front of them. One was green, one was yellow, one was red. So instead of having to be very kind of overt and obvious about needing help, all he had to do was sort of push one forward. So green meant, I'm doing fine. I don't need any help. Yellow was, I'm going to need some help with this when you get a second. And then red was, I don't understand. Please help me now. And then also teaching somebody how to request a break. So lots of different ways we can teach folks how to read in their body when they're going to need help, and then asking for it in a way that maintains dignity. As far as starting and finishing tasks, delivery is key. It's what you say and how you say it. So one of the things in the group home setting that we often dealt with was level of engagement. So instead of someone's in bed and you knock on the door, hey, do you want to get up and help me make breakfast? No, they're sleeping, they're comfortable, but they're not going to want to come out. So a lot of times just wording it differently, saying, I've got some bacon and eggs in the fridge. I'd love your company in the kitchen. Would love your company. Come on out and join me. So wording it like it's an invitation versus a chore or a directive. At the end of the day, they still have free will and the ability to make their own decisions. But sometimes just wording it just a little bit differently can make a huge difference. Chunking larger tasks into smaller, more easily manageable steps can be very helpful. Modifying task presentation. So doing something easy followed by something else they know, followed by something else that they have mastered before you introduce something that's difficult, to create behavioral momentum and boost confidence. I guess the personal example that I didn't realize it at the time that my parents were doing when I was younger was we had to do math flashcards every night, which seemed like ages to me when I was little, but it was very helpful. And we'd start with addition, and okay, that's mastered. Start with, and then we introduce subtraction, and then we have that mastered. So you would start out every session by doing something that somebody knows. Let's review some of the subtraction. Let's do some of the addition. Okay, now we're going to introduce multiplication. So just being aware that you want to kind of get the ball rolling as far as that confidence before you want to introduce something that's more difficult. Scheduling shorter work sessions. I've seen this manifested in a gentleman who would not get into the vehicle to go to OTPT and speech. And then if we actually were able to get him in there, he would refuse to get out of the van or go into the building or have a lot of destructive behaviors. And then we just sort of kind of on a very basic level looked at like, okay, what could be, causing that for him? What's so aversive that he's wanting to escape this? It was that they were scheduled back to back. So even for somebody without a brain injury, his therapy days were really hard on him, cognitively and physically. So instead of having OTPT speech back to back, we just scheduled them on different days rather than everything in the same day, and then it wasn't an issue. So kind of, again, just looking at the why. He was just frustrated. He was tired. Avoid scheduling challenging tasks at the end of the day when fatigue is more likely to be a factor. So just being considerate about sort of when you're doing that. Start again with starting and finishing tasks. There's something called the Premack Principle in behavior analysis, where it's just basically making clear the connection between behavior and consequences. So if you do this, then you earn this, or then this will happen. So hey, after you take that shower, we'll head out for your community outing. So basically just making things really clear for somebody. Um, Scheduling in controlled choice when you have the chance. So, as far as a daily shower, you want to take it in the morning or do you want to take it in the evening? What do you prefer? Kind of going back to a preference assessment. Um, there's so much independence and choice making ability that's lost and taken away after a brain injury. If we can give some of that power back to make decisions, it's very empowering for a survivor. And then as you work through a task with a survivor, providing a lot of praise and positive feedback to keep that momentum going, creating a visual task or visual of the steps involved in a task with pictures or text that they can refer to. And then practicing sessions to rehearse those steps out of a task outside of the task itself. So just scheduling practice sessions, whatever that is, whether it's learning to tie their shoes. So you're not gonna want to schedule a shoe tying lesson right before somebody has to walk out the door. Obviously, you're gonna schedule those in where the person can relax and focus on the task. So scheduling those in can be a really helpful thing too. Task analysis. So I've heard it referred as sort of creating a task recipe. So really breaking down in a big way the steps involved in doing a task. And there's something called backward chaining and forward chaining that can be used, and they're both very powerful in teaching skills. The first one is backward chaining. So if you had a goal of teaching someone how to put on a shirt, for example, you could break up that task into several steps. Pulling your shirt over your head, pushing your right arm through the right sleeve, pushing the left arm through the left sleeve, and then pulling the shirt down to your waist. So with backward chaining, you would work backwards, starting with step number 4, where you pull your shirt down to the waist. You would help the person do the majority of the task, except pulling their shirt down, and then providing positive feedback for completing it. So after they show you, okay, I can pull my shirt down, then you're going to introduce step number 3 and kind of work backwards. And you proceed in that fashion until someone is independently able to do the entire thing themselves. It increases interest and the ability to do a task. It makes it more manageable. It's less overwhelming, and it increases skill retention. Forward chaining is the opposite. So it teaches a task starting with the very first step, which is usually how people do it. So step number 1, if you're teaching someone how to brush their teeth, step number 1 could simply be the person independently picks their toothbrush out of a toothbrush holder. And then all the remaining steps in the process are prompted, hand over hand. So all they have to do is take it out. Everything else is assisted. Once that first step is mastered, then you move on to the next. And that could be picking up the toothpaste or unscrewing the cap. So it uses the behavioral momentum. Since the first step is often the simplest and the easiest, it can get somebody's interest a lot easier. Maintaining concentration. So accounting for fatigue, like I talked about, just never having that full battery, and stimulus overload by scheduling in those breaks. And then being flexible. So allowing for the ability to reschedule a task for a later time if the individual that you're helping doesn't have a lot of energy or motivation. Just being open to moving that to do it at another time is helpful. Asking an individual if there's some way that you can help them. So John, you appear to be really distracted. What can I do to help? A vibrating wristwatch. So they have these, and you can actually set them at predetermined intervals to go off, and they just simply vibrate in a subtle way, and it's just sort of a prompt, like, oh, got to get back to what I was doing if they're sort of in their own head and not really focused on the task. And then being aware of environmental noise, sound, sight, smells that can increase someone's ability to focus, feeling overwhelmed, getting agitated. So using things like hats, sunglasses, earplugs, white noise machine, a box fan to minimize those distractions can be helpful. And then there's the emotional behavioral impact of a brain injury. So, and you see this manifested in countless ways. Mental illness, like I said, schizophrenia, so you might see this with some delusions and hallucinations. Disinhibition and impulsivity, so that's just that poor risk assessment where somebody's speaking and acting first and thinking later. They're not connecting their present behavior with future consequences. Hypersexuality or inappropriate sexual behavior, it could be verbal, propositions, comments, questions, or physical. Extreme and often unpredictable mood swings. often, and working for a provider that in that group home setting, one thing that I often found was that there was a huge difference between the behavior that sort of prompted calling 911 versus what law enforcement actually saw when they arrived. So obviously 911 was called because things were at a level that was unmanageable. And we had tried everything we could. By the time the police got there, all of a sudden it's, oh, he's friendly and he's calm and things seem to be in control. Um, so I actually just did a crisis intervention training with Johnson County for first responders, and I really drilled this just to keep that in mind. Um, those mood swings that are often unpredictable, things even if they look calm, aren't calm. I worked with somebody who we thought he had de-escalated, and he reached out to shake the hand and apologize to the staff that he had scared. And he was smiling and appeared to be calm. And when she grabbed his hand, which in hindsight shouldn't have happened, he broke her fingers. So just keeping in mind that those extreme unpredictable mood swings can be part of having a brain injury. Low frustration tolerance or easily angered, anxious, restless, depressed, um, dealing with suicidal thoughts and or attempts. And then one thing I want to spend a little bit of time on is stages of grief, because I think this is really, really important in being aware of when you work with somebody, or if you're somebody with a brain injury. There is often not often, there's the survivor's experience as well as the people around them that love them. I heard a quote that is, one of the hardest things to do is grieve the loss of a person who is still alive. Um, Loving somebody with a brain injury or being somebody with a brain injury, you experience a death of who you were, of who they were, of who you are. And you have to work through that and create and adopt a new identity. Um, it's important, I think, especially in working with those, loving those, carrying those with a brain injury, is imagining losing just one of the things um, that a survivor can lose. Um, a spouse, custody of children, their job, their livelihood, the ability to earn money and have value in their day, driving, toileting, dressing themselves, walking, talking, ability to do the things that they love, like their hobbies. It would be just think in your own life, just losing one of those things would be absolutely crushing. It would be devastating. And often a survivor many times can lose all of those things all at once. And and that's why I think it's important to recognize that everybody has a story and get to know it, because if they're acting like they're pissed or they're sad or whatever it is, well, there's good reason. And it doesn't make the behavior okay, but it makes it understandable and relatable. Um, Denial, um, I like this. It says, you know, it helps us pace our feelings of grief. It's nature's way of letting in only as much as we can handle. And then the bargaining stage is kind of the what if and the if only stage of grief. There's a lot of guilt that comes in that stage. Like what could I have done differently? How could we have prevented this? Um, Grief is not a linear process. You don't move from one stage to the next, and there's no set duration for each stage, and it manifests differently for everybody. Um, I actually just saw this morning, an analogy that I want to read to you guys. I really love it. Um, it's called the ball and the box, and it's a grief analogy. Um, and I think I'm going to use this when the opportunity arises because I found it to be very powerful. So in some, there's a box with a ball in it, just like a diagram, and there's a pain button inside. In the beginning, the ball is huge, like if you think about it after a brain injury. You can't move the box without the ball hitting that pain button. It rattles around on its own in there, and it hits the button over and over. Almost any action triggers it. You can't control it. It just keeps hurting, and it often feels unrelenting. As time goes on, and it looks different for everybody, the ball will usually very gradually shrink, and the pain button is activated less often. The ball hits the button less and less, but when it does, it hurts just as much. And it's better because you can function day to day a bit more normally. But the downside is, though, the ball randomly hits that pain button when you least expect it. So you can be, we have here at the Brain Injury Alliance, we provide a service called neuro resource facilitation, where we work very closely um, with survivors, and we might close a case because they've they met their goals and we've worked with them for 2 years, and then out of the blue they call us back and things are really, really bad. So again, grief is not linear, and things can crop up. And for most people, that grief ball never really goes away. It might hit that pain button less and less, and you have more time to recover between hits, unlike when the ball was huge. And it's not, like I said, it's not unusual for certain pain triggers to cause that ball of grief to grow larger for a period of time after you thought it had permanently shrunk, or I thought I was doing okay, or and I get a lot of spouses that call and say, I thought things were okay, I thought things were better, and now they're really bad. And remembering that brain injury it doesn't live in someone's past, it lives in their everyday experience. As far as the emotional and behavioral impact of brain injury, just in general, providing frequent behavior-specific praise when someone does something that's expected or appropriate, feeding the behavior basically that you want to see more of. And then, again, seeking first to understand the why behind behavior, someone's story, identifying those triggers, learning the early signs of agitation and escalation. In my previous job, I wrote a lot of behavior support plans, and I always like to put this section in there so that the people, whether it was guardians or family or staff, that they knew, okay, when they're engaging in these behaviors, whether that's they ball their fists, they start pacing, their breathing changes, whatever it is, they know, okay, let's be proactive and start implementing some strategies because he's showing us that he's on his way. And then escalation, obviously that's much worse. It could be, physical aggression, things like that, but really laying it out so that anybody that interacts with that individual knows best how to keep them successful. Asking about coping skills, teaching coping skills, and creating a visual menu of what somebody could do if they need it. Oftentimes when we're stressed or frustrated, sad, we forget the tools that we have. So making those really obvious to somebody with a brain injury can be helpful. Expecting the unexpected. Like I said, it can be a roller coaster, and just always being prepared. Creating a safety plan. If you have a brain injury or you're taking care of somebody with a brain injury, having a safety plan that, if when escalated, this person tends to want to self-harm, or they will get physically aggressive. What do we do when blank happens? And then having that laid out so that you're always prepared for that sort of contingency. And then being aware as a caretaker or a professional of your own pain points or your own triggers. Hurt people will hurt people. So often your buttons will inadvertently or purposely get pushed when you're working through challenging behavior with somebody. And it feels very personal, and it's often taken very personally. It's not. It's the brain injury talking. It's the impact and the symptoms of the brain injury talking. But being aware, self-aware of what triggers you is a very powerful thing. Another aspect of the impact of brain injury is that perseveration or that brain lock. So what I found that can be helpful sometimes is if I'm talking to somebody with a brain injury and they're, for whatever reason, they're just really stuck on a topic, or asking the same question over and over, whatever it is, to gently redirect to a different preferred engaging topic, often by starting out acknowledging that I understand it's important to them, even if I don't understand why or agree. It doesn't matter, how they feel. It's important to them. Saying something like, I hear that talking about blank is really important to you, but I'm going to have to push pause on talking about that right now, and then we can come back to it whenever. Setting limits. So if you know that on a daily basis or frequently there's a certain topic that comes up, deciding on a predetermined time of day or duration of time where you're okay talking about that perseverative topic every day, where you say, okay, when I get home from work or whatever it is, or after dinner in the group home, we're going to set a timer for 10 minutes. We can talk about X. But then just setting those limits that it's not going to be this sort of continuous conversation. And it's not a cruel thing to do. I think it's a kind thing to do, because somebody who's got that brain lock, they're fixated, and not necessarily because they want to be on that topic. So helping them unlock from that can be a really kind thing to do. One thing that I've done before is a question book. So just a notebook where an individual can ask a predetermined number of questions per day. And I use this a lot in the group home setting where an individual might approach, uh, they try to maybe approach the residential supervisor or myself on site with just an endless list of questions. So just setting reasonable limits that, you can approach me when I'm on site and ask me 3 questions. And they might have 15 questions that they want to ask. So it also helps them to sort of differentiate between what's emergent for me and what can wait. And then the answers are noted so the individual can independently refer to them if they forget them later or doubt the answer. So it's a concrete, tangible sort of evidence, and it helps increase independence so that they can seek out those answers on their own. Obviously, this is going to be somebody who is able to read, but it can be a good tool. Perception. So this particular slide kind of really focuses on like hallucinations and delusions. So I have found instead of arguing with someone's sense of reality, because it's not right or wrong, it's just how they feel, and just sort of meeting them where they're at with their thought process. Instead of arguing with them about it, entering their reality with respect and understanding, and then mirroring it. Um, Oftentimes, our instinct is to say, "There's no, we're not videotaping you. There's nothing in the vent, but there's nobody standing there. I mean, they're hallucinating. There's nobody there. You're safe." They don't. That is not their perception. So mirroring their reality can be extremely powerful and helps to sort of diffuse things. So think, you're scared and frustrated because you see someone in the room with us that's yelling hurtful things at you, um, and that's terrifying. Let's figure out how we can make you feel more safe, and then focusing on increasing perceived level of safety. So instead of saying something like, I was working with somebody who would frequently visually hallucinate, and when he did, that person would curse at him, and I think even throw punches and even attempt to molest him. So instead of saying there's no one there, which is your instinct, there's no one there. Why don't I stand in front of him so you can't see him while we talk? Or let's go stand over there, away from him, because you're not going to change their mind. What they see is what they see. So meeting them is sort of in that place can be really powerful. She doesn't work for the CIA. I had a person serve that we were helping, and she firmly believed that the staff worked for the government and they were there to harm her and harm her things, and that they were videotaping her. So when the law enforcement came on a particular occasion, they did a beautiful job. So instead of saying, "Staff doesn't work for the CIA, calm down," they said, "Hey, let's step into the other room to talk, just you and me. We'll talk with staff later. Let's go somewhere where you feel safe. Let's talk. They don't need to be there." Sort of meeting somebody where they're at, and figuring out how to make them feel more safe. Power struggles and conflict resolution. So our reaction to a situation has the power to change the situation itself. Um, it all sounds very cliche, but it's all very true and all very powerful. People and situations are powerless without your reaction. This was something I had to work on a lot with staff, because they're dealing with some hard, very difficult, challenging behaviors. You can't change what's happening often, so changing your response is what you do have control over. And that's where your power is. Um, I always use this quote, and I think I saw it on Dr. Phil, but I love it because it is applicable, and it helps me when I'm in a situation where I feel like somebody just sort of wants to get into a power struggle, or we're just not going to agree. You don't have to attend every argument you're invited to, and it can't continue without your participation. I always think of that particular person standing in front of me, sort of waving an invitation, like, "Hey, come on, let's get into it. Let's have some conflict." And then just sort of in my head going, "Okay, that's not where we're going to go. That's not the direction we're going to take." And then not adapting to the energy in the room, instead influencing the energy in the room, sort of not matching the level of the challenging behavior. Many behaviors, although they feel like they might, don't require a response. Avoid saying things like "calm down" and "would you relax." Those for everybody tend to be pretty triggering, instead of helpful, because if that person knew how or had the capability of calming down, they would. And then instead of saying "calm down" or "hey, would you relax," make suggestions on how they can do that. "Hey, let's sit down. Let me help you." And I've coached, you just coaching somebody through how to do some deep breathing, or let's go sit outside for a second. in the sun. Let's do some deep breathing. Whatever it is, making suggestions on how to calm down rather than telling them to. Pick your battles. Again, I don't say these things lightly because I know they can be very, very difficult in the moment to do. Disengage and walk away. And then remembering, do you want to be right or do you want to be happy or do you want things to go smoothly? So I worked with a gentleman who woke up in the morning very angry for probably the first 3 or 4 hours of his day. You could not do right by him. So we all learned very quickly, if he told us that we offended him in some way or disrespected him, we didn't get to decide that we didn't, and because that was just opening things up for conflict. So instead of saying, calm down, like I didn't interrupt you, I'm listening, saying, I'm sorry that it felt like I interrupted you there. What you're saying is important to me. Please continue. So even if you feel like you did not do the thing they're accusing you of, just humbling yourself, it just makes things go so much more smoothly. Social skills. And I apologize for you guys all hanging in there with me. I'm trying to cover a lot of what I think is really helpful information in a short amount of time. So I apologize if I'm going quickly. As far as social skills, that's a big area where individuals with a brain injury need a lot of support. So really helpful visuals can be created and reviewed to pre-teach prior to social interactions. So things like I worked with a gentleman who his most challenging behavior was verbal and physical, sexually inappropriate behavior. And I made a very simple visual, 2 columns. One column was green and one column was red. And the green column just listed in big, bold letters what was okay as far as a physical interaction with staff. And the only 2 things that were on there were high fives and fist bumps. On the red side was everything else, touching any part of the staff's body, getting too close, even shaking hands. For him, that was a trigger because it was just an opportunity to kind of linger too long. So that visual was very helpful because we posted it in his room and in community areas of the house. Didn't have his name on it, so that it was just this constant sort of visual, and it helped the other folks as well. And then worked a lot with some individuals who, for whatever reason, frequently call 911, whether that's attention seeking or what have you. So making a visual that outlines specifically what is and is not an emergency, because everything feels like an emergency. Everything feels like it's level 10. Well, there are some things that staff can do. There's CPR trained and first aid, and then there's things that, yeah, this is 911 worthy. So visuals like that can be created. Um, my computer went to sleep and it did something funny. All right, social stories. And these don't have to just be for children. I've used them a lot with adults. It's all in how you format it. So they're individualized and short. For an adult, it could just be a paragraph written out or a few sentences. And it depicts a social situation that reviews both the expected or appropriate behavior versus the unexpected, what you don't want to see, and then the natural consequences of both. And then there's conversation starters that you can make in any sort of using whatever, often on a portable keyring, and they can keep it in their pocket or they can review it prior to going out into the community. Things like socially appropriate versus inappropriate comments, questions, or topics. Did this with a gentleman who was often very verbally sexually inappropriate at doctor's appointments with the nurses. So prior to going out in the community, we have a little pre-teach session where we reviewed what kinds of things he could ask and what he should not say. And then I've seen this done with kids, but again, it can be formatted to be for adults. Is all about me books. So it could be all about, staff member John, staff member Michelle, and it just goes through and it talks, or it just lists out very plainly, what are her interests? What does she like to talk about? Again, it's a kind of a person specific social skill visual to use. The emotional behavioral stuff, kind of wrapping up this part, is proactively and frequently checking in with somebody throughout the day just to stay ahead of that negative attention seeking. Differentially reinforce. This is just a fancy way of saying give bigger and better reinforcement for what you want to see more of. So if somebody uses a call light versus just yelling out to staff or having verbal outbursts, somebody saying good morning versus a sexual proposition, approaching staff to process feelings versus engaging in property destruction, use communication device instead of hitting. So you're going to feed the behaviors that you want to see more of. Oftentimes, for somebody who is engaging in challenging behavior for attention, um, they you and they're being aggressive or whatever, you're not necessarily going to get them to move and leave the space. Particularly, I'm thinking of like a group home setting. Um, so instead of having the individual leave the space, you might have to kind of think on your feet and have the rest of the residents in the house go on an impromptu community outing. Or if this is a family situation, you might have to have the kids go outside to play if so and so is getting escalated. That's kind of that always be prepared, have a safety plan in place. And then and I'm thinking of an example when I had a gentleman who during toileting and showering, things like that, he would be very sexually inappropriate towards female staff. So when you have the option, you can rotate in someone else, and if you don't, had to do a lot of training up with the staff on how to not give attention to those sexually inappropriate behaviors that are so easy to emotionally respond to. That's a really difficult one. And then instead, keeping the content of what they were doing, if she was having to help them bathe or get dressed, very task focused, very benign, only engaging when they're going through the steps, averting eye contact, that kind of thing. I don't have too much left. Thanks for hanging in there. The rest is kind of focusing on empathy and some self-care. So empathy is referred to as holding space or feeling with somebody. And this is just part of that whole getting to know somebody and just sort of stepping into their shoes and how it must feel um, to go through the journey that they're going through. The power of empathy is, I'm in it with you. I'm not here to fix you. I'm not here to feel it for you. I'm here to feel with you and let you know that you're not alone. Real empathy is sometimes not insisting that it will be okay. And that's often our urge is say, it's going to be fine, just positive. Sometimes it's acknowledging like, this sucks. It's not fair what happened to you. This is heartbreaking and I'm sorry. That can be a very powerful thing. And it's the ability to step in the shoes of another person, aiming to understand their journey. Um, it's an opportunity for connection. I worked with a client once who he lost something that was important to him, something he had drawn, and it accidentally got thrown away. So when I got the call, he was engaging in verbal aggression, property obstruction, physical aggression. It was pretty intense. Um, Instead of immediately calling the police, I asked if they could put me on speakerphone, and they told me what was happening. Steph told me that he had lost something important to him. So he's screaming and throwing things around, and I said, I got his attention. I said his name. I said, I can hear that you're really pissed off right now. I would be too. I know that because I can hear you throwing things and yelling, and I want to help you. We've known each other for a long time because I had history with him there for a couple of years. How you're feeling right now is important to me, and I'd love to talk to you about it. But I can't hear you if you're throwing things because it's so noisy over there. Do you think you can set down whatever is in your hand? Because I don't know, he had furniture or something. He was sort of walking around ready to sort of destroy something. So I said, can you set down whatever's in your hand for a minute so we can talk? And I know you can be a gentleman because I've seen you do it so many times before. Do you think you can do that for me for a minute? And again, that's not going to work every time, but it just sort of drives the point. Like I'm meeting him where he's at. I'm having empathy, understanding why it is that he's upset, and letting him know that his feelings matter to me. And that was lucky that time because he did calm down and the situation was de-escalated. I didn't tell him to calm down. I didn't tell him he was being aggressive or inappropriate because those are triggers too. I just mirrored how he was feeling so he felt heard. I like to include these too. So it's phrases that communicate empathy. They're very powerful. So I can see that you're hurting. Thank you for telling me that. My heart hurts for you. I can see that this is really important to you. I can only imagine how you must feel. And I hear that you're feeling blank. That's that sort of mirroring. And then saying, it doesn't feel fair, does it? Sucks. So again, instead of trying to tell somebody it is going to be okay, everything's going to be better, just acknowledging that right now it feels like it doesn't for you. And I'm so sorry. And I've had times where somebody has told me something so heavy and so horrible emotionally, I honestly don't have words. So I'll say, I don't even know what to say. Thank you for sharing that with me, for trusting me enough to tell me. How can I be helpful right now? And I can hear that you need space. I want to be here for you. I'll stay close. You can find me. and you're ready. Things that don't help, covered a couple of these. So calm down, just relax, take it easy. And a lot of these we say on instinct without really thinking about the message. Saying I understand. A lot of people will say this with very good, warm intentions of just trying to connect with somebody. But I have found when working with people, not just with brain injury, but with any major trauma or issue, saying you understand there's often a divide. Because I've heard people say, well, you don't. You have no idea how it feels. Don't say you understand because you don't know. So just being kind of aware what that statement means. You should still be thankful you can still walk, talk. At least you can still, yeah, I have memory issues too. It's part of getting old. So trying to relate, like, yeah, okay, I forget things, but not in the way that you do. You have a brain injury. So comparing is not always helpful. This is a big one. You're lucky to be alive. I've worked with a handful of survivors in the last 4.5 years who have their brain injury because they attempted to kill themselves. They hung themselves or shot themselves in the head. Absolutely horribly heartbreaking. So for them, they don't feel lucky to be alive. So just again, being cautious of sort of the weightiness of what some of those phrases mean. Um, just think positively, snap out of it. You have a lot to be thankful for. A lot of these on the outside don't sound horrible. Like, you do have a lot to be thankful for. But that's not the stuff they're necessarily focusing on. So just meeting them where they're at with their emotions. Maybe you're not trying hard enough. They're probably trying as hard as they can, given where they're at and then how they feel. You look fine to me. Again, with those survivors who aren't, quote, disabled enough, and you'd feel better if you stopped focusing on it all the time. Couple more slides. This last one, just caregiver. So just touching on compassion fatigue and self-care. Caregiving often, and I learned this through that process with my grandparents. I thought I had a good idea. I had no idea um, that caregiving calls people to lean into things like levels of compassion and selflessness and patience and development of a thicker skin, self-control, emotional strength, physical strength, and advocacy um, that you didn't know was possible until you're in it as a caregiver or somebody who loves somebody with a brain injury. Um, you can't take care of someone well if you yourself are not well. Um, Allow yourself to grieve, make room for it, give yourself permission to feel it. I can easily, I can say all day to a caregiver, just take time for yourself. You deserve it. You work so hard. It's a 24/7 job. I used to say that to my grandma all of the time until I really saw what it was like. She felt like no one else, if she wasn't there and she left for a couple hours to go run errands, something horrible could happen, or nobody could take care of grandpa the way I can. So again, sort of thinking about those things that, yeah, telling somebody to step out for a little while, or I would even say, you know, hey, grandma, you step out, go see a movie, go on a drive, go eat, whatever. I'll stay with grandpa. But she just never felt like she could. And a lot of caregivers feel like that. They don't trust someone else to take care of their loved one the way they can. Um, it's important for caregivers to remember you're not a miracle worker. Um, you can't move mountains. And I often feel this as a behavior analyst, like I should have the answers. I should have this magic wand. I should know, but nobody does. We can try our best with what we know and what we have, but we need to be realistic about what we have control over and what we can accomplish. Um, I think it cut it off there, but rehabilitation is a process, and it's a very difficult one. Recognizing and celebrating the seemingly small but very relevant steps towards goals. When you're in the thick of it, um, might feel like, yeah, we're getting nowhere with this. He's not making any improvements. He's plateauing. She's just she's not getting any better. Sometimes you're so caught up in it and it just seems so painful and negative that you're not seeing those things, but trying really hard, again, without sounding cliche, to find those seemingly small, and I say that because they're not, um, they're very relevant steps towards goals. And then looking for something positive in each day if you're able to do that. And then the last slide, just want to touch on to those that are listening who are professionals or survivors or caregivers. Um, the Brain Injury Alliance of Iowa, one of the primary things that we do, among others, is provide a service called neuro resource facilitation. That's one of the things that I do, and it's one of the things that Annie does, who introduced me, among others, here. It's a free service that helps individuals with brain injury, their loved ones, and professionals. We have all different kinds of people that call in. Survivors call, friends, spouses, children, siblings, doctors. It doesn't matter. It's for anybody who is caring for or has a brain injury. And our job is to connect them to services and supports that they need. And that's there's so many different ways that looks for people. Sometimes it's, they just want to be connected to a support group, or they want to go back into the workforce. So we get them connected with vocational rehab. We get them connected with counseling. Some people, I talked to somebody who wants to drive again. So he wants to find a place that will evaluate his level of safety. So there's so many different ways that this looks. And all you have to do is call or email the brain injury line. And then we have a fabulous intake specialist, Vanessa, who does a lot of our intakes for us, gathers some initial information. And then she connects that person to the neuro-resource facilitator that covers that region. So all of us cover large portions of Iowa and are well-versed in what those counties offer somebody with a brain injury. So they'll get assigned to us, and then we make our first call with that person, and then we find out, okay, is what you're needing short term? Are they just wanting the number to legal aid or support group, or is this going to be long-term relationship that we're working together? And we can work up to 2 years and beyond if necessary, where we're doing regular follow-up calls based on the goals that we set together. And that could I have some folks that they like to check in once a week. They just like to touch base, let me know that things are going okay. They like to update me. And then there's some where they're okay if we call them every 3 months and come to check in. So it's a very person-centered, individualized service that I think a lot of people still don't know is out there. So just wanted to share that with you. And let's see, 12:40, okay, a little over an hour. That is all I've got. So I appreciate, and Annie, I don't have access to like a comment message box.
Oh.
I can't get it to pull up. So I don't know if there's
questions,
but
I don't see any, but I'll give folks a second to enter any questions that you might have. So go ahead and do that.
I'm sorry to interrupt you, Annie. I did want to say too that sometimes the questions that I get after these presentations they tend to be complex, where some say, I have this person engaging in this behavior, what can I do? And it takes more time than, again, because I like to know the why and the function behind behavior. So it might actually take, if you have those kinds of questions, you can reach out to the Brain Injury Alliance or just contact me directly with some of those more specific sort of questions, and I would be happy to assist you with that. So just wanted to put that out there. Sometimes I have to often say, well, hey, that's a really good question, but it's going to take a bit more time. Let's connect outside of the presentation to talk about that. So.
Yes, yeah, good point. Yeah, if anybody has questions like that, like Courtney said, reach out to her, and she's a wealth of knowledge, as you guys can tell, so she would be great at giving you some feedback and some ideas.
Again, feel free to call or email. And enjoy your weekend. Thanks again.
All right, thank you, everybody. Have a good day.
Bye.
Bye.